ladies and gentlemen, and our viewers out there. So you're welcome to the SMS, that's the School of Medical Sciences at 50 Community Impact Series. And of course, it's a live broadcast, and it's good to be on the topic hypertension, the silent killer. So today, I have with me Dr. Lambert Appiah and also Dr. Yao Edubuachi. And they're going to talk about this theme. Let me tell you a bit about our panelists, Dr. Lambert Appiah and also Dr. Yao Edubuachi. Okay, let me start off with Dr. Yao Edubuachi, and he's a prominent cardiologist based in Ghana, affiliated with the Confanoche Teaching Hospital in Kumasi, and also a lecturer at the Kwame Nkrumah University of Science and Technology. And his research extensively focuses on various aspects of cardiovascular health in Ghana, particularly the prevalence, awareness, and management of non-communicable diseases, that's NCDs, like hypertension and diabetes. Let me tell you a bit about Dr. Lambert Appiah so that we don't because we're going to spend a lot of time here. So Dr. Lambert Appiah is a senior specialist physician and cardiologist, as well as a senior lecturer at the School of School of Medical Sciences at the Kwame Nkrumah University of Science and Technology, and also the Confanoche Teaching Hospital in Kumasi. Now, his research focuses broadly on global cardiovascular health, encompassing prevention, epidemiology, clinical trials, implementation science, and health systems improvement. Now, he's done a lot about stroke and also hypertension, but of course, I'm going to start with Dr. Yao Edubuachi. Now, his studies review a high prevalence of hypertension in Ghana, with a significant proportion of affected individuals unaware of their condition. For instance, in a 2019 study on awareness of screening campaign, he found that the hypertension prevalence of 27.3% among participants, with 2/3 of hypertensives unaware of their status. So we start with Dr. Yao Edubuachi. Doc, please tell about hypertension. And of course, let's go into how people are unaware of this condition. Why do we consider it as a silent killer?
Yeah, thank you very much, and very good afternoon to our viewers. We're in the studio this afternoon trying to bring a message to the community of the university, trying to raise awareness on the fact that hypertension is a deadly disease in terms of it having serious repercussions on morbidity, and also repercussions on mortality. Now, hypertension over the years have been a big risk factor for almost all the cardiovascular diseases that we can talk about, i.e. stroke, heart failure, cardiac arrest, heart attack, and we talk about peripheral vascular diseases. But be as it may, people seem to have an idea about hypertension, but they don't actually know the risk that it portends. And that is why this afternoon we've taken time off to speak about it as a silent killer, because a greater percentage of the people who have hypertension, from the studies that we did at the May measurement month in 2018 and 2019, it reveals that quite a number of the population have hypertension, and that is where in 2018, actually, we had percentages around 35% of the population having hypertension. And in 2019, it hovered around 27%. But it was very staggering to realize that about 50% of the people who had hypertension didn't know that they had hypertension. And even of those that knew that they had about hypertension, 25% of them really were not on treatment. So what it means is that quite a number of people have an idea that there's hypertension, might even have an idea that they have, but they don't know the dangers involved in it, and therefore they have not actually seen a doctor for that, for treatment to commence. And hypertension has been termed as a silent killer because the dangers that it predisposes one to internally happens gradually without any symptom. So for instance, if somebody has hypertension, the heart can be getting bigger and bigger and bigger over the period without, you know, he being aware or she being aware that he has had the heart enlarging until the day that a catastrophe will strike. For instance, you'll be home and you cannot breathe. Or you'll be home, you feel dizzy, and all of a sudden he cannot speak. Or all of a sudden he'll even pass out. That is, he might get a very fatal stroke. And for that reason, we speak of hypertension as a silent killer. That it can do a lot of devastating effect in the body without you knowing, for 10 years, for 15 years, without you knowing. And then on one particular day, a catastrophe will strike, and that is why we look at it as a silent killer.
All right, Doc, thank you very much for this explanation. We come to Dr. Lambert up here, and you are also the Ghanaian, the secretary, the General Secretary of the Ghanaian Society of Cardiology. Of course, you've done extensive research on hypertension. Now, let's look at how it is diagnosed. Take us through.
Well, thank you very much. Just to add to the, silent nature, unlike, if you have malaria, for instance, you feel some headache, some fever, chills. When it comes to hypertension, you don't feel anything until, as my colleague said, calamity, strikes. So you may know, for some people, they may be lucky, some palpitation, some headache here and there. But for the most part, people don't get symptoms and it just happens. So it makes it really, really, deadly, because at the time that it's knocking at the door, there's already a complication, And one of the things that I wanted to add is it also drives kidney disease in this country. No, so I as you know, I work also as the General Secretary of the Ghanaian Society of Cardiology, and as my colleague has already mentioned, the burden of cardiovascular disease, for the most part, is driven by hypertension. So with that hypertension, some of the complications, notably on our medical wards, are stroke. In fact, it will interest you to know that consistently in the second largest teaching hospital, which is Confanoche, the two most common reasons why people are admitted to the cardiac ward is basically heart failure, and then to the neuro ward is stroke. So those are the two if you like, bad sequelae of hypertension that happens. And all of these research that we have done, for the most part, shows that hypertension is the number one driver for both stroke and heart failure. So as the society, Ghanaian Society of Cardiology, one of the things that we do is that in the month of May, he's already alluded to it, but globally, 17th of May, it's designated as the hypertension, World Hypertension Day. So what the society has done is to create that awareness. So there's been lots of social media campaign on some of the myths, some of the knowledge that we all must be, equipped with to be able to fight hypertension. So in the just past, I would say May, that's about 2 months ago, that happened. This time around, there was a public health, public lecture, I should say, where the focus was on lifestyle modifications and some work that had been done, which shows how our diet has been impacted by urbanization and globalization. In fact, I was looking at some data which showed that in the 1990s, about 78% of students on KNUST campus or university campuses were very ambulant, could walk, from Mecca to you name it. But now I'm told that because of based on the data we have, a lot of them are quite sedentary, and only about 7.8% are actively doing some. So even within the student population, you can blame it on the numbers, you know, that is growing. So just to answer your question directly, a lot is being done in the space of hypertension. One of them is what we are doing to create that awareness that, look, this is killing a lot of us, and we need to know that it is the number one reason why somebody will come with stroke, number one reason somebody will come with heart failure, somebody will come with even kidney issues. So that awareness needs to come. One of the things that is driving this, and I always say it's salt consumption, you know. When we take salt, you know, or even in real life, if you take any food that is laden with salt, you realize that you take a lot of water. That ultimately would affect your blood pressure rise. WHO recommends that we do a salt, daily salt of, you know, less than 5 grams in a day. But I will tell you that the typical wache with maybe what we call willy and the shito, the salt in it is more than 5 grams at a sitting. So if you compare what our daily recommendation is for the day versus what we do consume per sitting, then you can tell that our salt consumption is very high. And particularly for blacks, we have what we describe as salt-sensitive hypertension, where if you increase your salt intake, blood pressure goes up. If you reduce your salt intake, blood pressure also goes down. So that's how sensitive we are. So indeed, if you're able to control your diet, reduce salt, and there's very simple ways to do this. One of the ways I have always advocated for, and may be difficult maybe for students, is if you do your own cooking, you know, you cook rice, you put salt in it. You cook stew, you put salt in it. You could start off by just taking salt out of the rice and then put a little bit of salt in your stew. With research has shown that within 2 weeks, you're able to untrain the tongue. So your tongue that you would say is used to this kind of taste, give yourself 2 weeks. If you do this kind of approach systematically and gradually, you will soon get to know that when you eat outside, you would appreciate the level of salt that we take. So it's one of the things that I really hammer on. Sometimes people say that, oh, I'm already used to salt. And my argument is that the same person who says that I don't, if there's no salt in it, I can't take, that same person will do Milo and consume it without complaining. You know, Milo doesn't have salt.
That's right.
That same person may even do rice water or even tea, what we call tea, and not put salt in it. So I always maintain that there's a lot of brain or psychological effect when it comes to taste. And once we are very, you know, intentional to control it, it's something that can be done. As they say, where there's a will, there's always a way.
Yes, and Dr. Yao, you have also explored the risk factors of hypertension. And Doc Lambert has talked a bit about the diet. Perhaps you can touch on other areas also when it comes to the risk factors.
When it comes to the risk factors that actually predisposes us to hypertension, the biggest one is actually age. So that as you age, you are predisposed to get hypertension. And even when we look at the prevalences and the incidence of hypertension, you realize that even though I spoke about the 34% in the 2018 May measurement month, if you actually stratify them by age, you realize that as people begin to go above 60, you are nearing about 50% of the population already being hypertensive. So age is a big risk factor, and usually I use this analogy that you can go to the pediatric or the pediatric end, and then you basically may pick about 1,000 children. You won't find one of them being hypertensive, except there is actually a secondary cause of it. But you just enter the adult ward. You can pick just 5 people, and I bet say that 1 out of 2 of them will be hypertensive. So age is a big factor. And also we look at genetics. So in terms of hypertension, there are a few risk factors you can't control. So age is one, and your gender, sex, more ethnicity is one of it. It's known from studies that the black race is more predisposed to hypertension because of the cell sensitivity that Dr. Lambert spoke about. And also, if your family, there's a family history of hypertension, so gender-wise, what do you call it, genetic-wise, if there's a family member who is hypertensive, usually in the first line, then you are also likely at a point to inherit those genes and then develop hypertension. So age, your race, and then the fact that there's a family history of hypertension are very strong risk factors that point to that. And those ones, you can't do anything about it. But there's quite a number of things that even though you have the predisposition, and as you are growing, whether you are black or you come from this area of the world, there is also the other environmental factors that come to add on to it that actually, skyrocket your chances of developing hypertension. And those ones are the ones that we are capable of doing much about. And I think Dr. Lambert has touched on one of the biggest ones, as in the diet that we consume. So if you're consuming a lot of food with salt, it is known that your chances of developing hypertension goes up. Now, beyond the food and the diet, we are also looking at stress. Now, stress is a big risk factor. And usually I look at, when some of my patients ask me, Doc, how would I know that I'm stressed? And I said, you don't need to know that you are stressed. In Ghana, everybody is stressed. So you should automatically make up your mind that you are stressed. But you look at the situation when you are coming to work in the morning, the traffics. Between your house and getting to campus alone is one stress before you start work. And then before you can get your children ready to get to school, that is another stress. And then you look at your finances. Now, if you are like my professor who is putting up a palace, then a big stress on you. Secondly, if you are trying to get your papers through for promotion, that alone is stress. And I remember today we were talking when my HOD said at the time that he was trying to apply for his professorship, he nearly went into depression. So all these are things that you look at, and they are all adding on to your stress. And then the more stress comes, these stress hormones are released. You get cortisol, you get growth hormone and other things coming in, and gradually they build up to developing hypertension. Beyond the stress, you look at other things. So when we look at hypertension, we look at the other risk factors there. If you are diabetic already, then your chances of developing hypertension goes up. If maybe you've gone to check on your lipid panel or your cholesterol levels, and the doctor has told you that your level of cholesterol is high, that one also puts you at predisposition of developing hypertension. For instance, and the body size also matters, the BMI, your weight. So if you don't manage the weight, there's something that we call the insulin resistance, which predisposes us to developing more weight. And once your weight is beyond the 25 kg per meter square, then generally you are predisposing yourself in developing hypertension. And the biggest one, which we always add on to the salt one, is about exercise. And that one, I beg to say that almost all of us are basically living some form of sedentary life. I mean, you come to think of it, you go to the Western world, and every community has a park where people can walk. But I've lived at Asukwa, I've lived at Tech before, I've lived at Odium. I mean, you want a place to walk, it might just be on some untarred road where you have to walk, and that discourages people. So places of, getting ability to exercise is actually limited in these areas. And also time, really, for people to walk. I remember during the COVID, I was listening to the news, and I realized that when the Western world was closing down, they gave the people some leeway to be able to do a one-day walk, some time of walk in a day, some 1 hour, 2 hours. But ours was just closed down, and you were home. And that is alone is a predisposition to developing hypertension. So these are some of the aggregated risk factors that predispose people to developing hypertension.
Great. Thank you very much, Doc. And I was happy when you talked about the diet, the salt issue. And, you know, people, before coming here, somebody asked me, well, we've been talking so much about salt, but what about sugar in the coloration? Or you can take as much sugar that you want and nothing's going to happen, but if you take salt, then something's going to happen. Perhaps you can touch on that. I know I'm delving a bit into more of dietetics, but
yeah. So like I said, if you have diabetes, your chance of developing hypertension goes up. So it's like a twin. People with diabetes, because of the predisposition to developing kidney diseases and other things, they stand a high risk of developing hypertension. But consuming high levels of sugar alone does not predispose you to developing diabetes. You definitely will need to get your pancreas not working at a point if really that will predispose you to diabetes. So sugar as an entity by itself, I would say, may not predispose you to hypertension.
Okay.
But if you develop diabetes, then your chances of going into hypertension sometimes goes around about 3 times.
Okay. And was somebody made an observation? I think you talked about insulin resistance. So somebody made an observation that when he eats too much of carbohydrate, then their blood pressure skyrockets. And so he was attributing his high blood pressure to the consumption of more carbohydrate.
So I would risk or hazard this explanation that I'm sure that whatever he's eating, that carbohydrate, you know, in it definitely is laden with salt.
Okay.
You know, but you know, it's like you say the cup is half full or half empty. It doesn't change the volume in the cup. So the risk is not subverted or obviated by the fact that he is focusing on carbohydrates. The salt is also part of the food that he's consuming, and you know, so sedentary lifestyle is one of the key issues, and you know, physical inactivity in itself. That is, you're not embarking on any kind of programmed exercise. You know, all of that also feeds into your risk. In fact, in Ghana, or maybe for the most part in Africa, and Dr. Dubachi touched on that, when your belly is spotting out, you know, pot belly, we consider it affluence, a sign of wealth. Oh, you're looking nice. So why? Because your tummy is bulging out of your clothing. But I dare say that it is only a matter of time. It's a time bomb, I should say, because with time, somebody who hitherto wasn't hypertensive, diabetic, would start ramping up on his sugar levels, will start going up on salt levels, just because there's pot belly. Because all the pot belly is fat, it's excess fat. And I always say that, you know, God has designed us. There's normal disposition of fat. We have fat in our palms, you know, sole of our feet, buttocks, you know, all of that. But when you begin to dispose fat to unusual sites, then those fat cells begin to act abnormally. So we say that the normal disposition is not inflammatory or is inert. But when you have ectopic adiposity, that fat then begins to excite inflammation. So that's how come somebody has pot belly, for instance. All of that you see is fat. That fat can seep into the liver, and you can develop fatty liver, you know, because that fat, they excite inflammation in the liver. The same way, as you swallow, if you're eating, for instance, and mistakenly you swallow, the body's mechanism is to trigger cough, so that you cough out. Maybe the food has gone into your the trachea to allow you to cough. The same way, if you do ectopic adiposity, the body tries to take away or remove that fat. So one of the things the body does is it increases breakdown of fat. So we call it fatty acid, oxidation or lipolysis. That results in free fatty acids. So the free fatty acids themselves are used in the synthesis of cholesterol. So that same person who has pot belly, with time, will develop hyperlipidemia. The same free fatty acids swim in blood. They get to your muscle. They prevent glucose in your blood from entering your muscle. So that is when he mentioned it, insulin resistance comes in. So insulin is there, but it's at the tissue level where it's supposed to convert or push sugar into the muscle. That doesn't happen. And it's all driven by just pot belly. The pancreas begin to think that, oh, maybe I'm not producing enough insulin. So it increases insulin production. So you develop hyperinsulinemia just by the fact that you have ectopic fat. That insulin can drive, it's an anabolic hormone. It can increase your blood pressure. It can increase reabsorption of sodium and salt. So one person, just pot belly, we are doing cholesterol, we are doing hypertension, we are doing also diabetes because the sugar is only swimming, it cannot be utilized. So when you see somebody pot-bellied, see that person in that lens that person is sitting on a time bomb. And that is why for those folks, if they engage in any exercise, that exercise will then help utilize that excess fat, and their sugar level, which maybe one time was up, begins to normalize. The World Heart Federation, WHO, there's a lot of data to show that if you engage in physical activity, then they recommend 3 to 5 times in a week, for instance, of moderate intensity exercise. You can climb, you can jog, you can, brisk walk, you can swim. All of that can prolong your lifespan by at least 1 hour when you're able to do this a week. So cumulatively, your lifespan is improved just by the fact that you are doing exercise. Exercise also releases some hormones that help your body to feel good, some euphoric feeling that you get. Again, exercise also controls your blood pressure. Exercise helps you to de-stress. And just to add to my colleagues, some of the sources of stress is just midterm exams in an ill-prepared candidate. Or you, as he mentioned, those who are in the working space, you could work in the bank, you could work somewhere, very audacious targets that you are giving. Maybe you are a marketing rep. You're supposed to bring in 10 new customers, you're a bank, whatever. That target alone places a demand on you. Let me also mention that person who has pot belly, that same excess fat adiposity can also happen even around the neck and can lead to something that we call obstructive sleep apnea. So you have patients who sleep at night, then while they are sleeping, they can cease breathing for some seconds, then they kind of get startled, they wake up out of their sleep. Some may be panting, some may be dizzy, just because oxygen doesn't go. When you sleep, the tongue falls back, oxygen doesn't go, adequate oxygen doesn't go into your lungs, you have difficulty breathing, the body will force you to wake up. So if this happens consistently, you realize that you have a very poor sleep, you wake up in the morning, you have early morning headaches, during the day you're watching TV, if you are not engaged, within 5 minutes you begin to doze off. So all of that puts a stress on the body. So you release some of the stress hormones he's mentioned, including catecholamines, which go up. When they go up, they drive high blood pressure.
One of the things that people have been advocating has been the keto diet. I don't know whether you heard of the keto diet. And since we've been talking just about the insulin resistance, then perhaps we can talk about the keto diet. So then they are advocating that keto diet will be very helpful. It's very helpful when it comes to these diseases, like cardiovascular diseases, hypertension. What do you say to that? Because it's now a trend.
As an academic, you always want to talk based on evidence. As we speak, guidelines have evolved since over the last decade, and it's predicated on level of evidence. There's nowhere in the guidelines for hypertension where ketogenic diet is endorsed. So I think I've answered the question. It just tells you that, look, let me tell you, it's what you're saying is like, and I always give this example to my patients. Oh, what about moringa? What about this? Look, kontomire is good and rich in nutrients, including even iron. It does not mean we should prepare a paste or a sauce of kontomire and be taking it 4 times a day.
That's right.
I don't know if you get what I'm saying. Everything is in moderation. So if you're doing ketogenic diet, which is less of carbohydrate, high levels of cholesterol, in fact, those that can do about 6 to 10 eggs in a day. What do you want to achieve? That
They were saying they are saying that it contains rather good cholesterol.
Anyway,
the HDL, the LDL, that it contains a good cholesterol. It's not a bad cholesterol. So then when you take it, it helps with vitamin D synthesis and stuff like that. So they think that overall it helps with their health.
yeah.
So ketones, as we know, is actually a secondary fuel. So the primary fuel usually is the glucose, and the secondary fuel, if the body is not getting access to glucose, then it's not getting access to insulin to be able to utilize the glucose. Then it falls on converting a lot of fats into that. So I think those who make those assertions are actually looking at bypassing insulin and then getting the ketones coming in directly as a secondary source of fuel. But I mean, if you look at nature is more wiser than us. Absolutely. There's a reason why I put it as a secondary fuel, not as the primary fuel. So the primary fuel is the glucose. So like you said, there's the evidence does not exist to show us that when we do a lot of those ketogenic diets, then we do. But rather, the evidence abounds for DASH diets, where it looks at less salt, and then promote more of the use of the greens, vegetables, and then because those have a lot of antioxidants and things that help with the body.
Okay.
So DASH diets, we have evidence for that one, but ketogenic diet, and the evidence is weak to support that.
And look, one of the things that people also, because I'm just looking at the public.
Sure. I mean,
I'm taking things for the public, so that it clears all these myths and misconceptions.
Yeah.
It comes down to minerals, because of course salt is sodium chloride, and people think that taking foods containing loss of potassium or magnesium, taking magnesium supplements, we help with combating hypertension, or cutting down or bringing down the salt levels. I don't know how that works. Is it that the levels of potassium tend to as a push the salt outside the body, or how does it work? And is it really true that it helps with hypertension?
Yeah. So as he mentioned, the DASH diet is actually rich in potassium. So and it's the DASH diet is one of the dietary regimes that have found its way into the guidelines. There's Mediterranean diet, there are other kinds of diet, but these two, and the whole concept is that, as I told you, wherever sodium goes, water follows. Blood pressure in itself, it's a function of cardiac output, and then peripheral resistance or systemic vascular resistance. So if you have cardiac output, which is a function of your stroke volume times heart rate, whatever you do that increases the blood volume will ultimately impact on your blood pressure. So doing that sodium, that is the effect in increasing your blood pressure. If you do diet that is rich in potassium, it offsets the hypertensive effects of sodium. So that's a benefit, and magnesium is relevant in the absorption and metabolism of potassium in the body. So clearly, those two are linked. Some of the deficiencies that sodium, should I say potassium, can impact on the body. Sometimes when you have been managing them, you have to add magnesium. They go in tandem. I would say that within our local community, that one of the food substances or food products that's rich in potassium, it's coconut water. It's cheap. Well, these days I'm careful when I say it's cheap because maybe five or 10 cedis may not be cheap, depending on what you said.
But, use it for
but relatively,
plantain has
relatively is cheaper. You get the water. Right. Banana is also rich in potassium. In fact, it will surprise you to know that the amount of potassium that you find in the typical, they call it abofukwedu, the longer one, not the asantikwedu, as they say. You're getting, for one, maybe about 12 millimoles of potassium, or even anywhere between 8 and 12. So all I'm trying to say is that natural foodstuffs are laden with some of these good things that we are talking about. When you come home to the kitchen, one of the food ingredients or consumables is tomato, very rich in potassium. So we encourage eating, but eating healthy is what we are focusing on. If you want to eat, there's a kind of salad that you can prepare, which is less mayonnaise, but you have just your tomato, your lettuce, your onions, your cucumber, and then maybe carrots without the mayonnaise. That is healthy kind of diet that you can do. You can add even one boiled egg, because don't forget, egg in itself, just one egg is a whole meal. It is when you do a lot of that, then the bad cholesterol in the yolk then can be problematic. So I would say that dietary-wise, we have a lot. In fact, we do have a lot of food stuffs that are rich in all the things that we need to control our blood pressure. The problem here, or should I say in Africa or in Ghana, is that people don't do the fruit. I mean, you need at least some 3 to about 5 servings of fruits, in a day. But you can imagine somebody struggling to even get cake to eat, and you're talking about.
Is very expensive because
the
you're looking at about 5 fingers going for about 30 Ghana cedis.
Yeah.
And I'm just wondering the number of people will be able to afford that every day.
You make a good point. It's expensive, but you see, it does not. It has no substitute. The good things in life, some of them you really have to pay for. If you want a good education, you have to sit and learn. So I think that, yes, I agree with you, it's pricey, but it's a necessary evil.
Wow.
Yeah, maybe just to add a little bit. So, like you said, potassium, physiologically, I'm sure our great grandfathers were practicing some of these things without any evidence behind it. They talked about the use of coconut water, as he said, the use of banana, plantain. These contain quite a number of potassium. But now scientific evidence have come to catch up with it, that even the latest European Society guidelines of on hypertension actually recommends that we take in more foods that have potassium. And just to say that some secondary forms of hypertension, when we say secondary forms of hypertension, these are hypertension where we seem to know what is causing it. There are primary causes, a greater part of it, over 95% of it. We don't have a disease entity behind it. But the secondary ones, we have a disease entity behind it. And one of it is actually when some persons are low in potassium. We usually look at it primarily as the Cone syndrome, that the potassium level is low. that no matter the amount of antihypertensives you give them to control their blood pressure, it won't come down until you start giving them potassium. So potassium plays a key role when it comes to hypertension. But I dare say that people should not go supplementing their foods with potassium. Like you said, we'll be able to get a lot of these from the foods that we eat. So it's just about rather making sure that you get those foods. And then talking about the fruits, I think one of the things we should be encouraging among ourselves is to going back to this subsistence farming system. That is how come we are buying every fruit, we are buying every apple, we are buying everything. But gone were the days, our parents were not buying all of this. They just go behind the house. They can get banana, they can get mango, they can get the local apple and all that. But these days, people have the land, because in Ghana, land is all over our places, but people won't farm. They won't do any subsistence farming. And that is a source of that relief exercise, what they call stress. I mean, over the weekend, you can go into the farm, do some weeding and all that. So we should be encouraging ourselves to going back to subsistence farming. Otherwise, we will be buying everything from our pocket, and that makes life quite expensive, right?
Yeah. And at the risk of sounding political, I was following the midday news today, and I think the 24-hour economy has been launched, isn't it?
Yeah.
And I think one of the pillars is grow 24. So I'm sure that that will be captured under that.
That's quite interesting.
And Dr. Edwache, one of your research works explored the effectiveness of specialized hypertension clinics and fit-based centers in improving screening, linkage to care, and also management of hypertension, and also type 2 diabetes. And noting some significant improvements in treatment and also control rates in such settings. Can you take us through how these also play a very important role?
Yeah, so that was one of the important studies that I decided to embark on, to see how, if you have a hypertension clinic which is led by a specialist who has more knowledge in that area compared to clinics which are being led by the general physicians, how it dovetails into control and how it dovetails into the patient being compliant, and then ability to pick risk factor complications quite early, and in order to prevent future occurrences which hitherto would increase mortality. So I looked at I looked at one area where quite a number of the hypertensive are referred from the general physician to see the specialists in the area of hypertension and cardiovascular disease, so that they see the initial cases and then they stabilize the patient, but then they send the patient over to the specialist physician who is more into hypertension. And the study, one of the things that we looked at was how the patient became more compliant and how the patients got less actual cardiovascular events. Now, the study revealed that in terms of risk stratification, so when somebody develops hypertension, the general person might see everything as numbers. So that if I'm able to bring down the hypertension from, let's say, 180 to over 120, and I'm able to bring it to 130, 80, I've done my job. The person is on treatment, and he can come to the clinic as and when he's scheduled to come. But then, that general physician might forget about risk stratification. So when someone has hypertension, two people have hypertension, and they all have the same numbers, 180 over 120, 180 over 120. Unfortunately, their risks are not the same. Because if I find a BP 180 over 120 in somebody who is aged 30, and I find that same in somebody who is aged 60, the age alone adds on another risk. One is diabetic, one is not diabetic. That alone brings an exponential increase in the risk. So hypertension, though we might be in the same class, we might find ourselves all in stage 1, stage 2 hypertension, the risk is not the same at every point in time, and therefore those who are specialists in hypertension, one of the things that they go further to do is that they do a composite risk stratification, so that they look at the total risk that a patient is exposed to. And there are various calculators that we use to do that. So for instance, immediately I pick you up as hypertensive. I look at the blood pressure level at which you came. But the other thing I'm asking myself is, this person, what's the age, what is the cholesterol level, what is the diabetes status, what is his smoking status, what is his exercise capacity and ability and all that. And then I put it together and I look at what we call the holistic risk of the person. And you will come to realize that the two people who had the same blood pressure, one may be at risk of developing stroke, maybe in the next 10 years at a rate of about 40% compared to the other person who may be just around maybe 5%. And therefore, if I'm treating the two of them, I am going to be more aggressive and with the one who has a higher risk than the one who doesn't have the higher risk. And that was what we observed, that if the hypertension clinic is led by a physician who is a specialist in that area, then the patient have the benefits of getting that, other assessments added on. And by that, they prevent the future occurrences of events. And that is why, I looked at that. And secondly, I also realized that in terms of compliance, the patients seem to comply when that one, it wasn't because they were seeing the specialist who was known, but those clinics are also clinics where there are nurse educators. So the nurses continue to do the education as to take your medications, do exercise and all that, and therefore allow the treatment to become very effective.
Wow.
And therefore, we were looking to do a broader study where we would rather try to use it to inform policy. That not that every hypertension clinic should be led by specialists at any point in time, but there should be creation of specialist-led hypertension clinics, probably in various districts, so that when the general physician have seen and have been able to control all the blood pressures and everything, they could be referred for those risk stratification. And as time goes on, it may encompass the practice holistically.
Thank you very much. Dr. Lambert Appiah, we know that most homes are laden with home-based hypertension, blood pressure measuring kits. Of course, you go to many pharmacists and they'll tell you, get this to your homes and stuff like that. So many people are using them. But that there's a problem with calibration. Our stuff are not really calibrated well. So you place it there and it gives you this figure, you place it that and it gives stuff here. What is the guidelines when it comes to the use of these things in measuring your blood pressure?
Yeah, thank you very much. And before I answer that, I recall that you asked me a question about how high blood pressure is diagnosed. Yeah. So I'll just walk us through that. It is very instructive to know that if you're checking somebody's blood pressure, that person should have at least rested for 30 minutes prior to the event or to the procedure. That person should have been off smoking, off caffeine, off exercise, because all the things that we have mentioned, and that person should have also at least emptied his bladder. All these things I've mentioned are things that can spuriously increase blood pressure. You would agree with me that these does not happen, or these don't happen in the clinics. So it is very instructive that blood pressure is not checked once. And when you are checking it, you have to observe all of these things. You can't check blood pressure in this position. Your feet have to be on the floor, your arm at the level of your heart, because gravity does affect what you call blood flow and the blood pressure for that matter. So you do all these things. When you're checking blood pressure, your back has to be straight. You can't check blood pressure with sitting up like this. No, your back has to be rested. And once that is done, then you can use these standardized automated machines. So they are the semi-automated ones or the aneroid ones where, it's the screen is there, but you'll be, inflating the bladder. And there's the fully automated ones which can do the BP measurement as long as you connect. Again, the size of the cuff is very important. If you take a smaller cuff, then you seriously increase the blood pressure. If you take a bigger cuff, you dampen the blood pressure or you reduce it. So it's important. And, every cuff has an inflatable bladder in it. So the length of that bladder should at least be, first of all, you should have the mid-arm circumference of whoever, the arm circumference. So 70% of that mid-arm circumference should be the length of your bladder, cuff, within the cuff, at least 70%. And 35 to 40% should be the width. So all of that is a derivative of your mid-arm circumference. So if you don't get the appropriate per individual, you seriously increase blood pressure. So I dare say that most of the blood pressure that I checked, if I'm in the consultation, for instance, if your blood pressure, you come and it's checked, unless you are getting consistently above 180, more than 120, it is something that guidelines recommend that go and monitor this blood pressure at home, or at least get what we call ambulatory blood pressure monitoring. So these are automated machines we have. We fit them on you for 24 hours. They check your blood pressure every 30 minutes or every 15 minutes, depending on the setup. And within 24 hours, we will know how your blood pressure does. It's important to mention that for most people, during the day, your blood pressure is high. At night, your blood pressure dips by about, 10, 15%. There are some folks who do the reverse. During the day, they come to you in a consultation, their blood pressure is fine. So I always say that, particularly if you're 40 years and above, if you are checking your blood pressure and it's constantly normal, you always have to know that you could belong to those people with a reverse pattern blood pressure, where during the day it's okay, at night it goes up. So those are the folks at dawn, they can come down with a stroke, heart attack and stuff like that, because blood pressure shoots up. So it's important to at least, once you are more than 40, get that 24 hours so you can at least know the pattern of your blood pressure. There are, as he's mentioned, specialist cardiology clinics, which can do some of these investigations, so that at least you know for sure that your blood pressure that you're seeing today that is normal, it's better and is the same at night and not the reverse. In terms of getting calibrating them, the guidelines recommend that these BP machines should be well calibrated. First of all, they should be standard blood pressure machines. As you know, we phased out the mercury sphygmomanometers for issues of toxicity. So now it's a semi-automated and a fully automated.
I was in a hospital, not to cut you, though. I was in a hospital setting when a man came and saw we were using the electronic one. And he says, no, these ones are not effective. And he wants the old one,
the one with the cloth. Yeah.
I don't know where he was coming from, but he was saying that they give the accurate results, not the modern ones, by the way.
I mean, there are settings where the automated one, the automated one, the principle is that it relies heavily on the strength of your pulse. The strength of your pulse. So we have something we call oscillometric method. That is the method that it employs to check your blood pressure. So if you are somebody whose heart rhythm, your pulse, is not regular, what it means is that the pulse that cuff will be measuring here would also not be regular. And it will confuse the sensor that is deploying the oscillometric method. So if your pulse is not regular, it could be regularly regular or intermittently regular, it will give you false readings. So sometimes even on the ward, somebody who has something we call atrial fibrillation, you check the blood pressure 10 times, you're getting very varied readings here and there. So they have their limitations. And that is why you use them either at home And in the hospital, at least where there's someone with insight who can do that. A lot of these newer ones actually have a knob called manual. So though it's fully automated, there's a manual knob. So when somebody is having issues with the pulse, you can switch to the manual one and use your stethoscope to augment it. They are heavily dependent on power source and electricity and battery, depending on which one you're using. So I would say that one of the things that also affects the calibration is that the battery has to be frequently checked. I always tell my patients that if you're checking your blood pressure morning, evening on the same battery, within 6 weeks or 4 to 6 weeks, that battery will run down. And if you don't change that battery, you use that same BP machine to check, it may give you spurious readings. There are guidelines, there are also recommended, calibration centers where you can take your fix for these to be well calibrated. It's a specialized tool that is used to make sure that what recording you are getting from your machine is correct. You know, I dare say that a lot of these machines that we're using around are not that calibrated, and therefore some of the readings may be spurious. So I think that is what I would say relative to that.
Hypertension, the silent killer. We're pressed for time. We're almost done. But, Doc, you've been engaged in this pacemaker. Of course, when these things happen, we're talking about interventions. Of course, stroke can ensue and stuff like that. But let's look at these interventions. These interventions like fixing the pacemaker, which you've been involved in. Perhaps a brief thing about it, then we can wrap it up.
Yeah. So I would say that one of the advanced therapies that is deployed for patients whose pulse rates are low, because for most people at rest, you're doing a pulse or heart rate between 60 and 100. There are some folks who, by some disease process, their heart rates are between maybe 20, 30. They are dizzy, they walk a little, they feel unusually tired, and they may pass out. So in time past, I would say decades ago, Konfanochi Teaching Hospital, for which is affiliated to KNUST, has been embarking on some pacemaker implantation, but it was purely based on mission terms. So you have folks from maybe the UK, US coming once or twice in a year to get these procedures done. But over time, and with the passage of time, indeed, both of us here on the platform have been, trained in that regard. And I would say that in the last about 2 years, it was actually occasioned by COVID, when, there were travel bans here and then. We had to rely on homegrown approach. So that's when we started the pacemaker program. I would say that over time we have over 50, 60 patients who have benefited from this pacemaker implantation. Indeed, if you don't put that device in, what that device basically does is that for your heart rate that is low, you put in, it could be a single wire or 2 wires straight to the inside of your heart to monitor the heart rate. If the pulse is not coming in, the machine takes over. So it saves lives. So right on the table when it's implanted, a patient whose heart rate could be maybe 20, 30, right on the table, it jumps up to normal, between 60 and 100. And they walk out, they can be discharged as same day or the following day. The challenge we are having with that, is that it is pricey. These are advanced therapies. It's costing somewhere minimum maybe $5,000 or more, depending on which model or which device you are buying. And therefore, it's out of the reach of a lot of people. So what we would want to, say is that there's a lot of help that we need in that space. As we speak, we do have close to 20, if not more, patients on the list who are financially incapacitated to buy these devices. And basically, we are falling on the benevolence of civil society, philanthropists or support groups, foundations across the world who may come in to provide either these devices directly to us so that we implant them, or they will come with some financial support. So I think that is a very good initiative, but we need a lot of support. And one of the supports we need is infrastructure, which is what we call the cardiac catheterization lab, where these procedures are done. So maybe at another time we can really delve deep into some of the things that we are doing, and the real challenges that will need urgent support, both locally and internationally.
Great. And Dr. Eduwache, the unfortunate happens, Dr. Lambert has talked a bit about, the stroke. But perhaps if you can continue with what should people do when they are attacked, when they are done, when you're having the stroke.
Yeah.
What is advice for these people?
Okay, so the whole issue about hypertension as a silent killer is to bring people to an awareness that because it does not come with signs and symptoms, you never get, quite a number of the time, you will never get a symptom to know that you have hypertension. One of the things that we are advocating this afternoon is that anybody who is above the age of 25 should get his blood pressure checked, should have a kind of screening done, get into the hospital, use your health insurance, get your blood pressure checked, and be told the numbers that you have. And if the numbers, like Dr. Lambert said, are going above 130, 80, then you should know that we have hypertension on our hands. And one of the things I would say is that quite a number of people do measure. They get to know that they have hypertension, but if they end up seeing a physician later, you realize that they just walked into a drug shop or a pharmacy and then they were given antihypertensive without seeing the doctor. I would say that that practice is not helpful. If for any reason a person is having a high blood pressure, which is challenging, and walks into a pharmacy, if the pharmacist is able to notice that he needs help, maybe he can start something small, but the idea is to direct him back to see a doctor, a medical doctor, for a proper assessment and also for proper education so that he can be put on that one. Because it doesn't really give symptoms. If any time you start getting a symptom, quite often than not, it is the beginning of a complication. So for instance, if you have hypertension and you start feeling that you are breathing, you are getting easily tired, and you are short of breath, it might be the beginning of acute heart failure situation or acute pulmonary edema, and therefore you need to see a physician. For instance, if, like I say, that certain symptoms, I can find it in a child, I will not be bothered. For instance, if I see a 1-year-old who is talking incoherently, it might just be trying to learn new words, and therefore that is how come he is. But if I see anybody who is 18 years or above talking incoherently, immediately draws my attention to the fact that this might be a stroke, and therefore I need to get a person. So either you're talking incoherently, you cannot raise one arm, you cannot, or you feel dizzy all of a sudden, and you cannot move your leg immediately, or you get a part of your face numb, or a part of your body numb, you should begin to get worried and get into the hospital immediately. Now, usually we look at stroke and we look at heart attack, so that if you just get sudden onset chest pain, usually on the left or in the middle of the or mid-sternal, you should head towards the hospital. But just that we say that if you get chest pain, or if you begin to see that your speech is difficult, or you have difficulty speaking, you cannot speak at any point in time, or find a weakness, that is where we say that one of the things you can do in the house to help yourself is to get a baby aspirin, 75 milligram, pop it, and then come into the hospital. That alone might save quite a number of people, or might prevent them from going on to, developing a full-blown stroke. But sometimes it might just be a transient ischemic attack which is happening. You take the aspirin, it will help by getting to the hospital and get seen. Dr. Lambert mentioned also about the acute renal complications. So sometimes when it comes to the kidney. Some people tell you that they slept and they woke up and their faces are a bit swollen, but they won't come into the hospital. Their feet are a bit swollen, they won't come into the hospital. Or that they've seen that when they urinate, they are urine foams. I mean, all these are early signs to tell you that you need to see a doctor because your kidney might be failing because of hypertension. Now, when it comes to our women, you know, hypertension presents in acute form, usually in their pregnancy. So they go, they get pregnant, they go into the hospital, and then sometimes when they are being followed up the 6th month or the 7th month, people begin to realize that their blood pressures are rising and they are beginning to get some protein in the urine. That is evidence of preeclampsia, or sometimes they even develop a stroke getting to the latter end of the pregnancy. That becomes eclampsia. And these studies have shown that the acute complications of hypertension in a woman presents more at a time when they have when they are pregnant, the obstetric complications. And quite a number of them, unfortunately, if they are not urgently addressed, leads to the death of the mother or the death of the baby. And therefore, when women are pregnant, I think we need to be on the high lookout for hypertension development in these patients, because they enter into the pregnancy, most of them may not be hypertensive at all, but during the pregnancy the blood pressures go up and these fatal effects happen. So these are some of the things.
Dr. Lambert, some last words.
Thank you very much. I would say that hypertension, it's a major driver of cardiovascular disease, not just locally, globally. And simple things, as we have been saying this afternoon, get to know your numbers. There's something called opportunistic screening. Anytime you swing by the hospital, you may be the patient, you may be an accompanying relative, take the opportunity to check your blood pressure. That may be just when you get to know that you are hypertensive. Thank you very much.
Thank you very much. So this is a community impact series brought to you by the ELEARNING Center in collaboration with the School of Medical Sciences, KNUST, as part of the 50th anniversary. So next time we're going to talk about, we have so many questions coming in that we needed to ask you, but unfortunately we're a bit pressed for time, but perhaps, Doc, if you can ask, maybe quickly answer these questions for us so that we can proceed. The influence of sex on hypertension, and also the high impact of white coat syndrome, where in the clinical setting you're having a different reading, and you know. So if you can explain on that for us quickly, on the impact of white coat syndrome on an individual, right, and also the influence of sex on hypertension.
Yeah. So when it comes to sex and hypertension, there's the first of all, I rather want to bust the myth. Now, people talk about the fact that men, when they take antihypertensive drugs, then their sexual drive comes down. Therefore, a lot of men, when they are diagnosed with hypertension, would rather stay away from, taking the drugs.
But is it true?
Rather, on the contrary, hypertension itself, because when we are talking about hypertension, we are invariably talking about blood vessels. And for a man to be able to sustain an erection, he needs a lot of blood for that purpose. So when you develop hypertension over time, and that is one of the unseen things that happen, that gradually you begin to develop atherosclerosis. And the same way you can get atherosclerosis affecting the heart, and you develop a heart attack. You can develop atherosclerosis from hypertension affecting the brain, and then you develop a stroke. The stroke for the male organ would be erectile dysfunction. So the vessels that feed it will also develop narrowing, and therefore over time you may also develop erectile dysfunction. So much as they talk a lot about the drugs causing it, quite a number of the times the opposite is the hypertension, which has stayed so long, and there's evidence to show that quite a number of men might develop erectile dysfunction from uncontrolled hypertension. The drugs, the truth about the drugs is quite a number of the drugs that we use for hypertension would not affect your sexual function. The ones that can affect sexual function, the doctors are aware of it. And quite a number of the time, those are not the ones we push our men
Okay.
onto. Those at the end of the day, those drugs are quite strong antihypertensive that we use in the emergency setting when somebody has come and his blood pressure is somewhere around 220 over 130 with severe headache and those one. We give those drugs. It brings down the blood pressure, and then we gradually transit them onto good. I dare say that there are some even antihypertensive that increases your erectile function.
Wow.
But just that they don't know, so they should see us when they and then the thing about sex itself and hypertension is that sex is also one of the good things that, because it produces a lot of endorphins to the body, feeling good and good pleasure. It actually reduces. It's also a stress relieving activity. And therefore, when done in the proper setting, it can bring down your blood pressure. And therefore, those who, a lot of studies have talked about 3 to 5 times of sexual activity within the week would actually improve hypertension, blood pressure. But in terms of the numbers, if we have to go by numbers, that how much drop will you have? Per a setting, it's going to be very difficult to say that to drop your blood pressure by 10 or 10, but there are studies to show that it improves sexual function. Therefore, it's recommended in the proper setting. And when I say in the proper setting, for those who are supposed to be engaged in it, it's not for those who are not to be engaged in it. Right?
Yeah, I would just add that, there's a good side. It's just like physical activity. You benefit, when you do engage in a very good, moderately vigorous activity, you feel good after that. It's similar to that. The question I would throw, though, is for those who would want to augment the process by,
aphrodisiacs.
Exactly. Opting for aphrodisiacs. Some of those side effects of those medications can even increase your blood pressure. And we should know that, as I said, exercise itself naturally will increase your blood pressure up to a point. So if you have a risk factor, sometimes your blood vessels may be loose. They may be a bit lax. When blood pressure, sharply increases, it can rip the vessel apart so you can bleed. I've had patients who have had stroke in the process. So if you have risk factors, which risk factors you may not know, I would therefore say that you should tread cautiously and actually stay away from aphrodisiacs. Or maybe see a physician first, But I think that the penchant to go in for aphrodisiacs because of demand, probably you're in your marriage or whatever, your spouse may be. And I'll just also sound a note of caution to the ladies to be gentle on their demands on the guys, because sometimes that in itself increases stress on the guy. And there's an inverse relationship. Once your stress levels go up, your sex drive and ability to perform goes down. So it's something that we need to strike a very delicate balance between them, because it's not really how long you last, but it's that union and companion.
Great.
Thank you very much.
I hope everybody is going to understand that. So Dr. Yao Duboache is a cardiologist, as well as Dr. Lambert Appiah. And thank you so much for the discussion. And next time we're going to talk about the prevention of kidney disease, hope for patients with kidney disease, and that's going to be the next month. That's what we're going to talk about next month on our community impact stories. We're having lots of questions coming in. I think someone is also asking if do pressure medication affect libido in women? That's a question somebody is also asking. I don't know whether you can also.
I think you first asked about the white coat effect.
Yes, the white coat. Yes, the white coat effect. Yes.
The white coat effect is one of the things I think Dr. Lambert talked about when he was trying to answer how blood pressure is measured. So, given the hospital setting, quite a number of the patients come in, and the hospital environment sometimes put them under stress. So some people are just afraid of coming to see the doctor, or somebody entered the hospital the concerns about there's death, a lot of sick people and all that, it raises their stress level. It makes them a bit anxious. So sometimes you check the blood pressure initially and you realize that the blood pressures are high. So the physicians are aware of this one. So quite a number of the time, like Dr. Lambert said, we would check the blood pressure twice, 3 times when such situations arise. And we may be able to realize that this is white coat hypertension. Quite often than not, the way around a white coat hypertension is actually to do a home blood pressure, so that sometimes we inform the patients to do their blood pressures at home before they come. So they bring the home blood pressure, and then we compare it to the hospital blood pressure, and you realize that sometimes there's vast difference between the two. In fact, I have a patient who immediately enters the consulting room. There's never a time that I've recorded a BP below 180, 110 for that patient. But immediately the person measures the blood pressure at home. He comes every time, the blood pressure is normal. I've put a 24-hour BP monitor for him, and I've realized that the blood pressures are basically normal. But each time he enters my consulting room, the blood pressure is 180, 110. Yep. Wow. So we do 24-hour monitoring for such patients. And usually it's now recommended practice that if you diagnose somebody with hypertension at the clinic, there should be home blood pressure monitoring or a 24-hour blood pressure in addition, to be able to augment whether your diagnosis is right or not.
But so I think these are done for all categories of
people. Categories of people. And in fact, about 25% of the people we find to be first-time hypertensives in the hospital, about 25% of them may have a white coat hypertension.
All right.
Yeah.
Doc, if you can add to the pressure medication and its effect on libido in women. Perhaps is there any research work to back that? Is it a myth? Is it something perhaps you've heard in the consulting affects libido?
I think that unless the blood pressure medication, maybe let me take it this way. The women on some medications may rather impact their blood pressure. Women on oral contraceptives, women on some kind of steroids, it may do that. The specific mention of libido, I do not have any scientific data to buttress the point that it would increase or decrease their libido. So that is what I will say. And just to add to him, just as mobile phones and technology has evolved, medications have also evolved. So side effects that hitherto existed in 1990, medications now are produced or designed to obviate or avert that side effect. And as he mentioned, there are indeed some antihypertensive that can actually improve your sexual function or activity. So in summary, there's something called a master plan for hypertension. So for when blood pressure needs to be measured very well and accurately, bearing in mind all the things that I have mentioned, the appropriate setting and all the things you have to be off. So A is to assess, once you've mentioned, and Dr. Dubois mentioned, once blood pressure is checked, you have to assess for evidence of what we call hypertension-mediated organ dysfunction. For somebody, the first time that blood pressure goes up is when that person probably has a kidney dysfunction. That person comes in unable to pee, and once you're not peeing, you retain fluid all over, including your face. So that person has already suffered a complication of high blood pressure. For somebody, it may be the first time he's had a stroke. So indeed, beyond ascertaining that you are hypertensive, assess the person's the sequelae or the complications of the hypertension. You can do simple things like urine, check the person's urine, is there protein in the urine, very basic thing, do an ECG, see a cardiologist, get a heart scan done. When you have high blood pressure, it is akin to somebody lifting metals. So the walls of your heart macho, they bulk up. So when we do an echo cardiac scan, we can tell if the walls are normal or not. So once we do and we realize the walls are high, ab initio, it tells us that this BP wasn't today. it's been there for a long time. So those are what we call hypertension-mediated organ dysfunction, which you can do. So that is the MA. The S is once we have confirmed this, then we begin to stratify your risk, as he mentioned. So you would be a high risk if you have something else beyond the high blood pressure. Then we start therapy. So the T will be the therapy. The therapy is dictated to by the hypertension-mediated complication that is present. Then the ER is we evaluate response. So whoever we have put you on treatment, the doctor will give you, come see me in 6 weeks or 4 weeks or 2 weeks, depending on the level of blood pressure. So that is a very basic thing that I think we can leave here with, that master plan for hypertension.
Quickly, if you can explain a bit, you talk about ECG. Those out there listening, perhaps you are talking about electricity capital Ghana.
So ECG is just an electrocardiography. So when the heart is like a house, so it has a wall, it has electricity, it has the pipe. So assessing the electrical activity of the heart, you place some leads on your chest and it will define the electrical activity. So if there is doom so happening in your heart and we do the ECG, we will know. Thank you.
All right, thank you so much again. In the absence of questions, I think we're going to wrap it up. So, Dr. Yao Oduwache and also Dr. Lamet Tetapia, thank you so much for this fruitful discussion. We're going to meet again next time. That's next month. We're going to talk about kidney disease prevention as part of the School of Medical Sciences at 50 Community Impact Series. My name is Kwesi Debra, and I'm with the University Relations Office. Have a nice day. Thank you so much.
Thank you for having us.
Thank you.